Good morning, everyone. Today I'll be talking about our work on transzonular drug delivery in phacoemulsification, which is an innovative dropless approach. We have no financial interest to disclose here. As we have all witnessed evolution of cataract surgery over the years with the innovative techniques, devices, and drug formulation. However, we still rely on topical medication to control post-operative inflammation, which is quite an effective route for controlling inflammation. However, there are certain issues which we deals with in the population that we deals with, like improper drug administration, poor compliance, and contamination of the bottles. And all these can lead to various complications. So to simplify the therapeutic effectiveness and compliance, various dropless approaches have been tried, and transzonular approach is one such route where the drug is placed in the vitreous through the zonules, and it remains there for a little longer and releases the drug slowly. So the patient can have a topical medication-free post-operative recovery. It is very effective in controlling post-operative inflammation, and since a single intraoperative injection is used, it is economically viable to the patient also. So we aim to assess the safety and efficacy of perioperative transzonular moxifloxacin and dexamethasone and compare it with the routine topical regime that we follow. And we compared it under the following heads: post-operative inflammation, change in intraocular pressure, and the visual acuity. It was a non-randomized study done on 100 eyes of 100 patients. The population was further divided into two groups. The transzonular group, it comprises of 40 eyes in which 0.15 ml of transzonular moxifloxacin and dexamethasone combination was given, and no post-operative topical medication were used. In the topical group, we had 60 eyes which were followed up with the routine topical medication. So any patient with senile cataract which is suitable for phacoemulsification and were willing to participate were included, and all those patients who had unstable capsular bag or zonular support, who had undergone vitrectomy, pseudoexfoliation, traumatic cataract, uveitis, or if any other intraocular surgery was planned along with cataract surgery, they were excluded from the study. So a standard topical phacoemulsification was done, and a stop and chop technique was used, and this was the injection technique that we used. So after the lens was implanted, the chamber was filled with viscoelastic, and we used a long tip 27 gauge cannula, and we went in through the main port across the chamber, and we tried to reach the sulcus, and once we felt the resistance, we withdraw the cannula a little bit and change the direction of the tip towards the vitreous and injected the drug. And if you are in the right place, you can see a wave of fluid over here. So this is the drug in the anterior vitreous. So the eyes were then assessed for inflammation, intraocular pressure, and visual acuity on day 1, 3, 7, and 28. Statistical significance was set as less than 0.05. These were the patient demographics, and we can see over here that the patients were comparable in all these aspects in both the groups. We compared the pre and post-operative intraocular pressure in both the groups and found that there was no change in the significant change in the intraocular pressure on day 1, 3, 7, and 28 in either of the group. We also compared the post-operative IOP changes between the groups, and throughout the follow-up period, we haven't seen any significant change in the intraocular pressure between the groups. We compared the inflammation in the anterior chamber in terms of the cells and found that there were higher grades of inflammation were seen, significantly higher grade of inflammation was seen in the control group on day 1, 3, 7, and no inflammation was seen on day 28 in either of the group. We compared the flare, and again we saw higher grades of inflammation in the control group on day 1 and 3. However, after that, no significant inflammation was seen in either of the group. As far as the visual acuity was concerned, both the groups have similar visual acuity at the end of the follow-up. We can see over here. And we haven't seen any major complication like zonular injury or capsular break. However, two of our patients had minimal bleed during the perioperative period, which stopped spontaneously and it didn't require any measure. So we conclude that the transzonular approach, it has got a greater therapeutic and tolerance response as compared to the conventional topical regime. And also it offers better compliance and cost effectiveness to the patient. There were certain limitations for our study, like a small sample size. It was mainly because of the COVID situation. It was a non-randomized design, and a flare meter would have been more objective in our study. Thank you.
Good, but the dexamethasone has an action of few days maybe?
Yeah.
But how do you expect the inflammation to be very controlled at the end of a month? Or what was the recurrence of, mild redness or mild inflammation in the group where you are given the transzonular injection?
We haven't come across any inflammation after a week or so in the transzonular group, and I think that the most of the inflammation that we come across is during that period only. So,
because from time to time we see patients whom when we reduce the topical steroids at the end of a month or 6 weeks, there is mild recurrence of inflammation. But theoretically it should be more in the transzonular group, because dexamethasone here acts for a few days and then just goes away.
Yeah.
And there is no other drops. Anyway, thank you.
You see, the thing is, as long as if the surgery has gone absolutely fine with no complications, in normal phacoemulsification, you can afford to stop topical also within 3 weeks and nothing happens. So there is no reaction. The same thing is applicable here. If there's been a complication, this will not be enough. You will have to supplement later. The problem again remains that this is an irreversible procedure. God forbid your patient develops end-off or something, you are stuck, you can do nothing about it. So for the little advantage that you are getting, maybe 1 in 1,000 patient, if you lose, I don't think it is worth it, but it is being tried. I mean, it's there. So.
But as you said, sir, the irreversibility is not a big thing like a triamcinolone, because this is just for 24-48 hours. But the biggest problem is we ourselves introducing organisms into the vitreous cavity by injection. That's much riskier.
Everything has gone well, but because you have done something, you may harm the patient. So actually, I was going to ask whether the consent of ethical committee was taken, and you had told patients also that we will be doing this, and everyone has consented. Okay. Yeah, I agree. But okay.
And how much time does it take to absorb the drugs?
Sorry?
From how much time? No, it must be taking a very short time for full absorption. Means clearance of the drug.
The drug lasts for like maximum 5 to 7 days.
No, clearance from the body, from the aqueous vitreous, from the eye veins.
The half-life of DEXA and the vitreous is...
There is a risk, no? As you said, there is a risk, always a risk.
How was that injection prepared? Can you just tell?
We prepared, we took the preservative-free moxifloxacin.
You can tell the brands, no issues.
Vigamox we used.
Okay.
And we used the dexamethasone.
How much of Vigamox was used?
Vigamox we used 0.05 ml of 0.5%.
So you took it in which syringe?
We took in a 30 gauge
syringe. I'm talking about. Huh?
Dispovan.
1 ml syringe.
1 ml, 0.05 ml. Okay.
0.05 ml and 0.1 ml of dexamethasone.
But generally for beginners, this is risky procedure because you are increasing the vitreous pressure.
Yes.
So when you are doing the IA, because they are doing it under viscoelastic, you can have vitreous prolapse through the zonule. So it's only for very senior people.